We are constantly looking for speakers to tell us something we may not already know, especially in the medical field. Today with us, please welcome chiropractor Mark Saracino. He's making his way up. He was recommended to us by several attorneys in the Philadelphia area. He's a member of the American Chiropractic Neurology Board. He has a broad background, which includes athletics and performing arts, and he's going to talk to us today about chiropractic neurology.
I'd like to thank Beverly and Norman, who were kind to organize all this, and Sonny Banks, who invited me to come and speak with you fine professionals. My late uncle, Albert Persichetti, was an assistant DA for Frank Rizzo back in the day. And Ernie Priate's father and my grandfather were best men at each other's wedding in Italy back in the day, in the middle of the last century, or the beginning half of the last century. Hello, everybody. I'm Dr. Mark Saracino. I'm a chiropractic neurologist. I've been in practice 35 years in King of Prussia. Chiropractic neurology is a relatively new subspecialization within chiropractic. It requires 3 years of additional education in the functions of the brain and nervous system, in a very similar way to how medical neurologists get additional training. I believe a 2-minute short film is going to be shown now.
The brain. It is the most mysterious and complex organ in the human body. The way people perceive the world is determined only by how effective its nearly 30 billion neurons work together. But when something goes wrong, Parkinson's, Alzheimer's, ADHD, dystonia, these are just a few of the damaging disorders that affect millions around the world. Recovery from these conditions and even injuries that were once seemingly out of the question are now achievable. New research is showing us how amazingly adaptable the nervous system truly is. New neural pathways can be created. With simple interventions, doctors have found ways to actually rewire the nervous system.
Things that are miracles are things that you don't see very often. But if you start seeing it all the time, then what was once a miracle is just a clinical expectation.
Follow us on a journey through a new frontier of medicine. A frontier that inspired a junior Olympic athlete to become a doctor to help others who suffer from neurological conditions that she herself experienced.
There's no amount of activity that I ever did as an athlete that was as painful as that stuff.
And visit the parents of one special young girl whose physical needs are outweighed only by her gracious spirit.
I worried, will she ever live a normal life outside of our house?
These people, like many others, have had to endure the hopelessness that comes when the body breaks down and becomes its own worst enemy. This is their story. This is Hope Restored.
Chiropractic neurologists treat many of the same conditions that regular chiropractors and orthopedists treat: neck, low back, and other extremity problems. I don't manipulate the spine as often as a regular doctor of chiropractic, whom I think often does it too much. We were taught not to crack our knuckles too much when we were younger because the joints would get larger, and indeed they do. Same thing with the spine. You shouldn't loosen those ligaments and support structures excessively. Spinal manipulation produces a phagocytic burst, which is a tremendous increase in the white blood cells in the body. And it also produces a release of endorphins, which are produced in by the glial cells in the brain. Endorphins are a very powerful painkiller. They make us high. We produce endorphins ourselves by getting excited, by exercising, by drinking coffee, eating sugar, laughing, and having sex. Spinal manipulation does the same thing. I try not to keep patients on a regular basis in my office. I try to find the final solution for them. And that often requires that I have to perform deep soft tissue therapies. I use little tools to get right in between bony structures. When you perform soft tissue therapy, you increase the flow of blood to the arteries. Where the artery ends is called the anastomotic bed, and at the end of an artery, there's a small space, and then there's the beginning of the vein. The artery delivers oxygen, nutrients to the tissue. After the tissue is finished with that, those vital nutrients, it expels them into the venous drainage system. That's called the anastomotic bed. Deep tissue therapies break adhesions. Adhesions are excess repair fibers in the body. When a muscle's in spasm for more than 2 days, adhesions form. The brain recognizes that or thinks that that's the normal position of the muscle, a shortened version of its regular length, and it sends repair fibers to the area. So turning off the electronics to a muscle and getting it to relax by whatever method isn't good enough after a few days. If an adhesion is formed where there was a scar, whether it be surgery or tissue damage, that's good, but the adhesions that are on a tangent to where they should be are not good. They disrupt the blood flow through the area. I think you can imagine if you have an adhesion in your bicep muscle and you're trying to throw an underhanded softball, and the adhesion is on an angle to the longitudinal axis of the muscle won't be able to contract lengthwise to a shorter version the way the brain had intended it to be, as well as it once did. That's why big, strong bodybuilders don't do very well playing tennis or throwing baseballs. The larger the diameter of a muscle, the more it forces the muscle's longitudinal axis to move away from the midline of the bone. And we were programmed in our brain, in our cerebellum, to know where we are in space based on where the muscles are relative to the bones. Physical therapy modalities should be employed. There should be a mixture of soft, hard, and physical therapy modalities and exercise and stretch rehabilitation for your clients who are receiving any type of rehabilitative care. Exercise rehabilitation should not be based just on tonnage, which is the amount of weight that one can lift, but the speed in which one can summate or create a muscle to turn on. Assuming that the patient hears the order and their frontal lobe, the behavior center agrees with that the doctor wants me to turn this muscle on and resist as quickly as possible, and if the muscle can't turn on as quickly as it should on one side of the body versus another, that means something. That's summation. Summation is more important than tonnage. If you're right or left-handed, it doesn't really matter. Myofascial contracture is a better phrase to use than fibromyalgia in describing the excessive formation of tangential adhesions in the muscle. Home instruction should be given to patients. That should be part of the initial month or two of therapy, and you should see that in the progress notes of the doctor so that the patient is held responsible to that. I think the judges and the carriers want to know that the patient is involved and that you're giving them things to do at home. Cold pack therapy is very effective. It decreases the blood supply to an area that's about to inflame. It decreases the speed and amplitude of the nerve irritation that's bringing that pain information up to the brain. An analysis of one's daily living activity is critically important. You could be leaning on your elbow on the console in your car. You could be reaching up for something in your cupboard every day that seemingly isn't traumatic, but it could be very much so. These things need to be noted in the progress notes. Concussions can occur without receiving a blow to the head. Concussions can occur without losing consciousness. You can get a concussion from slipping and falling onto your rear end while going down the flight of stairs, for example. Most concussions occur from a blow to the head, and all concussions involve the neck. 70% of all headaches originate in the neck. 70%. And that includes migraines. Migrainous cephalgia, migraine headaches, are often overdiagnosed. A lot of people use the phrase, oh, I'm having a migraine. Most likely they're not having a migraine. Cluster tension headaches are more common and they're more severe. The muscles in the back and the neck, if they're in spasm, they cut off the blood supply to the back third of the skull. That creates visual dysfunction and other maladies that are very similar to concussion. There are 6 nerves that come out the top of the neck and move backward and then rotate up around the skull. one around the ear, one halfway up the skull, the other all the way up the skull, coming out of this hole that sticks out, that's a little bit below that bone that sticks out there. If we all feel right now with one of your fingers, the top of the eye socket, you'll feel a little V. Above that V is a hole. That's the frontal foramina. Out of the frontal foramina comes the frontal nerve that goes to the frontalis muscle that elevates and depresses the eyebrow. This muscle, the last one that I pointed out that starts where the hole is in the back of the head that goes all the way to the vertex of the head, commingles with the frontal nerve. That's why you can get visual dysfunction from cluster headaches and from migraines and, of course, from concussion through the outside of the skull. All of these additional considerations should be part of any report that you receive. If not, you should ask your doctor to make comments about that. Blows to the head take up to a month and a half to 2 to get to their worst level. A month and a half to 2. Certainly you want to do an MRI or a CAT scan of the skull right after a major head trauma, but it should be done again in 2 months. When we sprain an ankle, it swells rather quickly and right away. We can almost see it swell. Pain, swelling, immobility. You sprain a knee, you see swelling, but it takes a while to get there, and the quadricep muscles get weak when we walk and we kind of buckle. When the low back is in spasm, you don't see any spasm. It's deep, but it's in the capsules, right next to the bone, right next to the nerves as they exit the low back. When the skull swells, there's nowhere for it to go. The cranium doesn't expand, so it envelops onto itself. That's something that's very important. Some diagnostic tests should be taken, like I said, up to 2 months later after initial head trauma. Another consideration for concussion is that, for example, if you were struck or if your client is struck on the top above the left eye, it's not where the primary impact is that the brain will be affected, it's the secondary impact, 180 degrees away from that point. So if you're struck here, it's the bottom part of the temporal lobe on the opposite side of the skull where most of the damage is. Similar to whiplash, which is not the primary, if you're rear-ended, not the primary moving backward of the head onto the neck, but the secondary movement that imbricates the articular facets in the spine and irritates the nerves. How can you prove that a patient has a concussion? First, come to the realization that it's 180 degrees away from the area of impact, and that there are centers in the brain. A center is where many of the neurologic pathways of a particular function either run through or are housed. The cerebellum is a part of the brain, the back of the skull, about 2 inches above the neck, about an inch above the skull line. It has to do with inhibition. It inhibits our body from moving through space. If there's an injury, the behavior center of the brain will tell the motor strip to activate, but the cerebellum isn't going to allow that to happen if there's pain there. The cerebellum also inhibits movements of the eyes. The parietal lobe on the left side, for example, allows you to have volitional eye movements to the left, and the cerebellum makes sure that eye movement doesn't go and become hypormetric. That's a term that we use when neurologists and ophthalmologists use special testing, as you saw in the film, optokinetic testing. If your eye follows an object and can't stop, or it stops slowly, and you would expect that if your eye is following an object quickly, that it will hit the brakes, but not as quickly as if it follows it slowly and then moves in a sinusoidal pattern, let's say right to left. You would expect a little bit of excessive motion, then the eye would rekindle and find that line, and then, I have to make a left turn and then kind of miss it and then go like that. Like how my wife complains how I drive sometimes. No, I'll make a left here. So I make a quick left turn. Hypermetria is where the eye excessively moves past a point. Now we have the ability to document that hypermetria or hypometria occurs. You should get those reports and prove that that's what's going on. Hypermetria, where the eye moves beyond where it should go, can cause a lot of visual headache and concussion-like symptoms. You may have all the reports from all the neurologists and ophthalmologists, but you need someone who can correlate that information so that your argument is convincing. We have volitional eye movements, and I'm using other examples of how concussion is manifested in the body. And we have involuntary eye movements. If we're the passenger in a car, we look at a sign as it passes, we look at it volitionally, but our eye is clicking onto it and moving away from it, always returning to the midline. It's called a pursuit and a saccade. The pursuit can be slow, the saccade can be too fast. It can be in one eye versus another. It all has to do with various centers in the brain. As I mentioned before, the parietal lobe is the motor center. It pushes the eyes to where we want them to go, and indirectly with reflexogenic changes, like with pursuits and saccades. But the cerebellum on the opposite side slows it down and makes sure that it's on target. Just like when we hit the brakes in the car coming to a stop sign, we get off of the brakes a little bit so our passenger's head doesn't lurch forward, and we don't add that additional torque to the suspension of the car. How to characterize concussions. They're global. Like the general malaise, if you know about them. Concussion in our society is much more understood, although we know more than what we did 10 or 15 years ago. We're going to learn a lot more in the next several decades. Every high school, and I believe junior high school, coach has to go through a concussion training period in addition to bullying and toxic substances and the like. So the awareness of concussion is very high. Is it being overdiagnosed? I believe so, but it's more that the awareness is higher and people are more cognitive of it, especially post-concussion syndrome, which occurs many years later. Compounded by swelling that stays in the brain in areas that affect specific centers to specific body functions. And as I described earlier, the excessive tangential adhesion formation in muscles. Muscles don't have memories. Muscles don't have memory. The brain has a memory for them. And if a muscle is damaged, it's going to assume that that's its damaged state for the rest of its existence. The joint won't be able to move as well as it did. The viscosity of the synovial fluid will increase. These all may sound trivial to you, attorneys who represent clients with head pain, but if the doctors that are working with you aren't providing that specific information and elaborating on it, you're going to have a much more difficult time convincing judges that the patient is suffering in more ways than just the classic concussion symptom reports: malaise, altered speech, diminished memory, fatigue, irritability, personality changes. The vagus cranial nerve is the 10th cranial nerve. It goes all the way down to the digestive tract. One other cranial nerve leaves the cranium and only goes to the upper trap, the muscle that elevates the shoulder. We were all very happy in the neurologic world when the new diagnostic codes came out, ICD-10. I'm sure you're familiar with them. They're alpha and numeric codes that you see on the HCFA forms. They're more specific. Prior to the ICD-10 implementation, which was about 2 years ago, there were maybe 5 or so headache variations. Cluster headache, chronic headache, intermittent headache, migraine, and concussion was concussion with loss greater than 30 minutes or loss less than 30 minutes. Now there are 20 or 25 or so. And it's great because now we know that convergence insufficiency, which several judges that I know of have accepted as a legitimate sequela and result of concussion, is something that can cause a lot of disturbance. You know, a shark can sleep and turn one eye off while it continues to swim and take in oxygen through its gills, because it can turn half of its brain off while the other half is on and protecting itself. We can't do that. Our eyes are right in front of us, and convergence is a very important function. It's done as simple as the convergence test, and then with one or the other eye opened or closed. It's easy to document as well. Getting back to the vagus nerve, it goes all the way down to the transverse colon, stomach, duodenum, small intestine, which is about 30 feet long. Large intestine is about 10 feet long. You can have abdominal discomfort from concussion. You can have altered assimilation and digestion as a result. That can be documented by a gastroenterologist, but the gastroenterologist has to put in his report, this could be vagal stimulated as a result of concussion. All the tests in the world and all the technology aren't good unless they're correlated for the purposes that you need to convince a judge that your client is suffering a lot. Another not often talked about subject that occurs is having to do with the periosteum. The periosteum is the covering of the bone. Bones themselves don't have any nerves, they don't feel anything. That's why stress fractures aren't often felt until the periostei is abrupted or swollen. If we all feel down to the front of our shin, we'll feel little bumps. Those are periosteal reactions from us banging our shin on various hard objects. And this is a conceptual description of it, but I think it's apropos. When they're swelling, there are large, medium, and small molecules that accumulate between the periosteum and the bone. After about a week or two, the small molecules will depart through passive diffusion, just by gravity and by pressure, they'll go out. The mid-sized molecules will stay around for several months, as you might have known when you irritated your elbow or hit your shin. But the large molecules are the ones that often stay. And once again, the body recognizes that as normal. It sends adhesions into the area and hardens it. After 6 months or so, it's now hard, but still sensitive because the periosteum is elongated. The nerves in the periosteum, once again, bones don't have nerves, the periostei do, are now pulled and they're irritated. You can have a periosteal reaction, which is where those large molecules calcify, anywhere where the blow was received. The doctor should continue to treat, and I'm pointing to the area above my left orbit because that's what I used as an example initially. That area has to be manipulated and treated with physical therapy means and contrast therapy. The Edinger-Westphal nucleus is the nucleus in the brain that's about 3 inches deep to my fingertip that's responsible for convergence. If the blow is to the back of the head midline, then you know it's 180 degrees away from that point where most of the swelling is. That could affect the Edinger-Westphal nucleus and the prefrontal cortex and all the other behavioral areas of the brain. Have your psychiatrist or psychologist document that. Have your clinician correlate that. Blow to the back of the head, swelling in the frontal area, it would affect one's behavior. Broca's area. Broca's area is the center for speech. It's right about here. It's in the lower part of the parietal lobe. A blow to the side of the head will affect that. If you've ever seen a professional boxing match and you see a boxer receive a blow to the side of the head, you would think that his speech is altered, and many times it is, but they also lose consciousness or they lose their balance and they fall and they're knocked out. So any blow hard enough to any part of the brain can cause a constellation of symptoms that you would normally associate with other more specific areas. So to relate the anatomic part of the body, where the brain has complete control of, to the specific area of the brain that is swollen or irritated, I think is convincing to workers' compensation judges. In the ear, for our ability to keep our head level and to stay balanced, there are 3 semicircular canals, each one responsible for different motions of the head. For example, when you turn your head to the left, a horizontal semicircular canal on the left side, which is rotating in this direction, it feels more rotation when you turn the head to the left. If you're ever in your car and you're the driver and you open the door and make a right turn, you'll feel the centrifugal force pushing that door outward. That's the same thing that happens in the semicircular canals. But each of them have a responsibility to tell the brain where the brain is in space. How does it relate to concussion? The horizontal semicircular canal has a different neurologic center than the one that's on an oblique, and then one that is the vertical one that has to do with head positioning, bobbing forward and backward. There are now diagnostic codes for ophthalmic migraine, vascular headache, abdominal migraine, allergic headache, tension cluster headache, craniocervical syndrome. occipital neuralgia, mild cognitive impairment, mental state, not thinking clearly, unspecified cognitive functions and awareness, abnormal head movements, seemingly small, big to the people who suffer, and you know, because they come and they complain to you. So the best way to document concussion is to have your clinicians collect as much data as possible with the basic considerations of where the brain is most likely affected. Have someone to correlate those diagnostic tests to create a nice narrative. And I think that'll be the best solution for you. Don't be afraid of concussion, go right after it. If your doctors use the diagnostic code concussion, but they don't use any other adjacent or congruent or concomitant diagnosi, I don't believe that's right. You can't have a concussion without it affecting the neck. You can't have a concussion without it affecting headaches and causing headaches. These things need to be documented for you. Do you have any questions? I'm a clinician, I'm not a researcher. There are research articles that are posted on Facebook concussion profiles. You can go there, you can befriend it. Excuse me. Some of them are only available to doctors, but I'm sure if you requested from the person who regulates that, they would include you in it. You would see how what I was describing as the volitional movements, the pursuits, and then the saccades, how they can be documented. And how, for example, the left eye saccade to the left is hypermetric compared to the right eye saccade to the left. Now it can be documented in little squiggly lines. They may not seem effective to you. How is a judge going to believe this? Once one little line deviates like that, the other ones are all straight. You have to emphasize that. Make sure that the doctors that do those tests understand the importance between one side and the other and how it relates to the brain. Any questions? Beverly, can you show some of those, Catherine, on my Facebook profile? And scroll down, please. Keep going, please. Keep going until you see a blue symbol right there. And that, for example, is one of the PubMed Medixix, I don't know how to pronounce it properly. Indexes is another place. You can get one page of a research report. There's no copyright impingement. That page is very informative. You can use that in court. You can ask your specialist to comment on whether there is a validity with that. That's just one article. I posted several others on my Facebook profile and on my website. There are other videos on my website. You're welcome to use them. Show your clients that yes, you may be suffering from a headache, and although you may be on a different part of the state practicing, you can just tell them that concussion is substantial and you need to go to somebody close to home, someone that you refer them to. Thank you very much.